Hi, we're back. So I want to go over some possibilities for pre-oxygenation with intubation. And I came across a YouTube video. I'm going to see if I can share this screen onto this Zoom meeting that I'm using to record this with. And I will try to include the link to this YouTube video. I'm not trying to pirate his video or anything like that. I'm actually highlighting it and hopefully sharing it, and he can, folks can go to this person's channel. But this is, well, let me see if I can share that screen. Let's see. I'm gonna share desktop number 2. All right. So this is the MCRIT page, mcrit.org. And as I was doing some research on optimal pre-oxygenation, one of the things that's, of course, in your job, preparation is key, right? So plan ahead, be prepared. Assume that you're going to intubate the next patient and just be prepared for it. And when you don't have to, wonderful, you're prepared for the next one. So how to pre-oxygenate with lower risk. A high flow nasal cannula carries extra risk. A non-rebreather carries extra risk, and a BVM and mask carry extra risk for aerosolization. This video here shows an alternative that is quite interesting, and we'll go ahead and watch it and see what you think. Okay, I had some technical difficulties. This is the best video and audio that I could get out of this. Hopefully it works well with the device that you're listening on. I think this is worth watching.
Scott Weinger here for the MCRIT podcast. Today, I wanted to discuss 2 items that I've been thinking about for our COVID-19 patients. The COVID intubation pack, which contains all the items you will need to do the intubation that aren't already in the rooms, aside from intubation medications, video laryngoscope, and a non-invasive mask that is non-vented. You'll see what I'm talking about in the video shortly.
Okay, so this is in an emergency department setting. This could be modified for your ambulance rigs. I'm not trying to pirate this guy's YouTube channel. In fact, you can see here, and I'll try to include it in the link in the description where it is, and you can go straight to it. But this appears to be an attempt to help others, and so we're going to use it. Looks like a good effort at pre-oxygenating in a way that has less risk of aerosolization, that less risk than a non-rebreather mask, less risk than high flow nasal cannula, less risk than bag valve mask, oxygenation. So this is using a BVM with a non-invasive CPAP type mask, basically, non-invasive pressure ventilation mask with a non-venting adapter, a CO2 detector, or in his case, an adapter for a CO2 monitor, and a PEEP valve. And the PEEP valve is important in that you can set the oxygen to high flow. The bag acts as a reservoir, so it doesn't blast the patient and cause aerosolization. And with the PEEP valve on there, even set at 0, it creates sort of a simulated closed circuit. It's not closed in the sense that they are exhaling, but they're exhaling through a viral filter. And as long as there's not leak around the sides, there's no exhalation that isn't gone through the filter. If there is leak out through the sides of the mask, it is generally going to be low flow and lower risk than all the other things mentioned earlier. So This is a neat little system and something that can be discussed, looked at as a lowest risk, possibly. That's up for debate and discussion with your company, but it is certainly intriguing and I think worth watching. So let me get back to the video. And I apologize for the jumpiness of the video. I reduced all of the demand on the computer that I could, and it just seems like this is the best that I could get.
The other thing we'll talk about is the safest way I have come up with to pre-oxygenate a patient with high FiO2 and, if you need it, CPAP without putting staff at risk. In fact, this is, to my mind, the safest pre-oxygenation that can be done. Safer in my mind than a non-rebreather mask at high flow, and safer than a nasal cannula. So take a look, and then please go to MCRIT and tell me what you think. Peer review it. Tell me if I am flawed in some way. I would love to hear your thoughts, because we are all working on the cutting edge of evidence. This is all based on knowledge of previous events and knowledge of the systems we're going to be using. All right, let's get to it. So here's the COVID pack. What you're going to need is one of these packs that's pre-made. You need a properly sized, non-invasive.
Now, the more the camera jumps around, the more herky-jerky it is. So sorry about that. It'll get better. A little bit.
Which are over there, not for the hospital's open circuit BiPAP machines. But we're not going to be using them with a BiPAP machine. I'll teach you what we're doing. You also need a CMAC or a bioscope and medications. And everything else should already be in whatever room you're in the EDIC. So I'm going to run you through the pack. Now, what you're going to do outside the room, if you have a moment, is you're going to take your viral filter. It would be in a package. This one happens to be open for this demonstration. And
now, if you're practicing limited partner exposure and one person's in the home or where you're picking up the patient and the other one's in the rig, of course, you can work out your policies and procedures or use your clinical judgment and common sense of how you would do this. But this could all be prepared in the rig before you even get the patient in. And having as much put together and set up beforehand limits the amount of times that you have to break the circuit to do the intubation. But this is all about pre-oxygenation right now.
Attach it to the non-invasive mask. And you're going to get your nasal cannula out. And you do both of these things before you go into the room. And we'll tell you in just a second why we're doing these things out before you go in the room. But hold that thought. So those are two of the items in there. Now the rest of the stuff is, it's either going to be a full face shield or a hood, depending on the availability. A BVM, and the mask for the BVM, but we're not going to put that on because we're not going to be using that, hopefully. You're going to have your end-tidal CO2 adapter, your end-tidal CO2 tubing.
I'm not sure what you're using, whether you're using instant CO2 detectors for intubation or if you're using end-tidal monitors.
These are the items you need that aren't already in the room.
Safe pre-oxygenation with or without CPAP?
All right, so we've now entered the room. We are in full PPE. It should be bunny suit, N95, surgical mask over the N95, some form of eye protection, preferably full face visor or hood, and double gloves. We're just for the purpose of this demonstration not going to be doing that. And the reason we took these three items out ahead of time is the first thing we're going to do before we set up for our intubation is we're going to get the nasal cannula on. And we're going to do that. It doesn't need to be on oxygen. In fact, it's preferable for it not to be right now. And then we're going to cover the patient with the non-invasive mask and the viral filter already firmly attached to it. Because as soon as that goes on, the only exhalation that's going to hit you is what's going to be leaking out of the side of the mask. And once this is on, we are a lot safer.
So he says what's going to be leaking out the side of the mask. There doesn't necessarily have to be anything leaking out of the side of the mask if it's a good fit once you get it on and in place. And so you're in personal protective equipment, PPE, and the patient is essentially isolated, exhaling through the viral filter.
That was pretty good. Now there's a little resistance to this, but can you breathe okay, Pamela? Yeah. All right, we're gonna make that feel a lot easier in just a sec. Now, for the pre-oxidation portion, we have a BVM with a PEEP valve, and the PEEP valve is at 0, and we already have pre-applied the end-tidal CO2 stem. I'm going to firmly attach that, and we're going to put that up to 25 flush rates, because the flush on a BVM has nothing to do with anything that goes on at the mask. The only time he's accessing the option is when he takes a spontaneous breath. Now, if we wanted PEEP, because the stats are not good pre-oxidation, we're going to put the nasal cannula up to 4.
So again, we've kind of closed the circuit, breathing only through the mask and exhaling only out through the viral filter. With the PEEP set at 0, that helps to create this simulated closed circuit. So, now what he's saying is if that itself is not enough to bring the patient's oxygen up, then you can dial in, well, first of all, you turn the nasal cannula up to 4 to 6 liters. That is going to pressurize the PEEP valve, and it's going to, even at 0, you're going to start to get a little bit of resistance, and then you can dial your PEEP valve up. And since the flow is really only being drawn from the bag, it's not pressurizing from the bag, because you're not squeezing the bag. But when you add the flow from the nasal cannula, now you can actually use your PEEP valve to build up PEEP, or PEEP and CPAP are synonymous. PEEP is positive end expiratory pressure, and CPAP is continuous positive airway pressure. They're the same. So this is a nice system.
And you can't quite hear it, but he is already powering this PEEP valve. Now this is only generating anything to the air that's not.
You can hear a faint hum as he exhales.
There's a leak around the mask, which right now I'm not feeling any. And his spontaneous breathing is going to pull the mask into his face. There's less potential of aerosol than a non-rebreather, and the same potential as a low flow nasal cannula. So this is the setup we want for pre-oxygenation.
Not squeezing the bag.
It's the best situation.
As long as they're spontaneously breathing.
And 100% or close to it FiO2, because that's what these BVMs provide, so long as they have a PEEP.
So you have essentially put CPAP on the patient without putting them on a CPAP machine that has to be decontaminated. All of this is disposable equipment. This is nice.
The PEEP valve is there both for PEEP, but also even when it's at 0, it prevents any room air inhalation, and therefore forces it to come from the reservoir and the bag to provide a high FiO2. Protecting the staff, the only thing coming into the room is non-high flow leak around the mask. If there is any on Pendle's face, there's not. We have 2 mask sizes. Pendle is a medium. Take a look at your patient. If their face is really big, grab a large. All right, folks, so let me know what you think at mcrit.org. I have a whole bunch more airway and intubation resources for COVID-19. These views do not represent the views of my hospital, of Janus General, or any organization. They are solely the views of me. And if you want to do any of this, you need to vet it with your local system to make sure they think it's clever too. Scott Weingart, MCrit Podcast, saying bye-bye.
All right, excellent. So let me show you where that came from. emcrit.org /mcrit/COVID-airway-management/. All right. again, this is going to be determined on a policy with your company and what you find on the ground there. So I am not a policymaker for your company. This is just information. But what I've been reading and understanding, and you all can discuss this, and that is once somebody goes on a ventilator, survival rate is fairly low. And the last numbers that I had encountered was about 80% people did not come off successfully. So they are doing everything they can to try to keep people off of the ventilator. But if you have to intubate somebody, or you suspect that an intubation may be imminent, then pre-oxygenating them like this would definitely get you ahead of the curve, so that if you do have to intubate, you have the best pre-oxygenation that you can get. The other thing that it seems to be making a really big difference is proning. And I don't know what your policy is, or if that is something that is feasible for you, but even proning with just a nasal cannula has been adopted by a lot of organizations. And what I'm understanding is that, yes, ARDS, acute respiratory distress syndrome, is a big culprit here, but they're finding that it's not just ARDS, or maybe in some cases not primarily ARDS, in some of the reading that I've been doing, but atelectasis. And this might be why proning is has been shown to be, at least anecdotally, very, very beneficial, and a lot of organizations are leaning in that direction. I know that here in Anchorage, my wife works at a critical care unit, and they are proning patients as often as possible. That's, of course, very challenging once somebody's already committed to a ventilator, but it doesn't have to wait until they get to the ventilator with your individual patients. So,
one last thought. This system that he's using with the bag, with the BVM, the non-invasive pressure mask, and the PEEP valve with the viral filter, something like that could potentially be adopted to bleed in a nebulizer treatment as well. That could at least be experimented with and see whether or not, I don't know if that filter would become overloaded with the nebulizer mist or not, but it is something to consider, a way to deliver a nebulizer and potentially reduce the mist that is being expelled into the atmosphere. That is something that you could consider experimenting with.